This webinar, The Financial Value of Care Coordination, is part of the Minnesota Path to Value project and is sponsored by the Minnesota Office of Rural Health and Primary Care through a grant from the Health Resources and Service Administration. Care coordination is a part of every Path to Value project. Often when I think of care coordination, I think of it how it's a workflow, it's how our intended population works through our healthcare organization and has their needs met. It plays a key role in effectively meeting the needs of your intended population and achieving your organizational measures. It also plays a large role in enhancing the hospital's finances. And the panelists for this webinar will talk about how the intended population can be affected and also affects the bottom line of the hospitals. Our objectives for today is that by the time the webinar is done, we hope that you will understand how care coordination is an essential part of value-based payments, how a full range of care coordination positively impacts the hospital's financial bottom line, and which services are currently reimbursable and which services lead to greater patient volume and revenue. To discuss this today, we have Terry Hill, who is the Executive Director of Rural Health Innovations and the Policy Advisor for the National Rural Health Resource Center. We have Ralph Llewellyn, Partner in Ide Bailey, and Carla Wang, Senior Program Manager at Stratus, and Amanda Wentzman, Healthcare Home Supervisor from Lakewood Health Systems. And with that, Terry, I turn it over to you.
Thank you very much, Deb. So when Deb came to me and asked, you know, our participants are really interested in the financial aspects of care coordination. And I think, first of all, we're going to establish that we're talking from a very broad standpoint here. In fact, we often refer to this as community care coordination, which means that beginning with emergency medical services to home care and all the services in between, as well as the services provided directly within the hospital, she asked who would be good resource people to do this. And I was excited about it, not only because of, this project, because I think we can take this particular example and record it and then use it as a resource for what is an increasing number of questions coming in about how do we make population health pay? How do we make care coordination pay? For adding these additional services, how can we make them pay? What is going to be the financial bottom line? So when I think about those, or when our National Rural Health Resource Center thinks about them, probably the person that we first go to is Ralph Llewellyn from Ide Bailey. And Ralph is just a principal advisor for our center, has been for many years. He and I did a series of workshops last year in Nebraska. And this question came up repeatedly in the workshops of the rural hospitals as we made our way down the road, et cetera. And then, he is, in my opinion, the best person to talk about a lot of the financial advantages of the, kind of working with the community, expanding your outpatient revenue, et cetera. And then I thought of Carla Wang, who is with Stratus Health at the university, at Stratus. And she works with the University of Iowa Rural Health Research Center, RUPRI, and they are a part of a project that is looking nationally, as federal funding to look nationally at what is happening in these value-based payment models. So I want to express thanks, both of them, for being part of this panel. I'm also the Senior Advisor for Rural Health Leadership and Policy, so I do a lot of work in this area as well, and I'm just going to be the moderator. And then we know that Lakeview is just such a great hospital. It was really good to have Amanda here to help us on this panel as well. So with that kind of an introduction, that kind of expression of appreciation, I'm going to start out with kind of what is the future of hospital payment. So as we're looking, I just got a really interesting statistic from one of the rural health researchers about the future of payment, but I'm going to ask Carla to step in here. So as we look down the road, Carla, another 3, 5, 7 years, what's our future rural hospital payment system going to look like?
Yeah, thanks, Terry. And I did put a link to the Rural Health Value team in that chat, so folks are aware of the resources on that team as well. So this is a big question. I'm happy to try to take a stab at this to give us kind of some grounding as we talk about going forward. So it's actually been 15 years since the Institute for Healthcare Improvement, Don Berwick and Co. put out their original triple aim paper, which talked about kind of quality plus experience over cost as value. And that framing has driven a lot of our conversations around what it looks like and what the payment system is going to look like. A lot of those concepts were built into the Affordable Care Act, which has kind of set up the Centers for Medicare and Medicaid Innovation and sort of drove that forward. So 15 years since we've been talking about this. I think both Ralph, Terry, and I have all been talking about that this entire time. And I think the way we talk about it continues to change because the landscape continues to change. I think in the early years of the conversations, it was sort of like, well, this is for the big systems, not really sure this is going to take hold. I think there's always been a recognition that the current straight up fee-for-service payment system was not sustainable in the long run when you look at healthcare costs and healthcare, how that's rising. But where rural fits into that equation has been unclear, I think, until a little bit more until recent years. So there is a big push currently, even a bigger push currently. In 2021, the Centers for Medicaid and CMMI, the Centers for Medicaid and Medicare Innovation, put out what they call a strategy refresh. And in that strategy refresh document, they've actually said that by 2030, which is not all that long away, they would like 100% of traditional Medicare beneficiaries to be in what they're calling an accountable care relationship. So essentially, they really want to have all Medicare traditional payments be aligned with value and cost. So we've seen goals from CMMI before. They've always been such that they always seem to have an asterisk that says this might not apply to critical access hospitals, rural health clinics, and FQHCs because you all get paid differently. And so a lot of the payment changes that have been happening from traditional Medicare haven't necessarily worked for you or you haven't been eligible to participate in them. But now they're saying 100%. That means there's not an asterisk that kind of allows rural to be left out of this system. So I think that's one of the big things that we're seeing change. We're also seeing CMS under this current administration really talking about equity and addressing underserved communities. And they have rural as a key component of that. So they have definitely been working on how do we make these models actually work in underserved communities, including rural communities? Whether or not they've actually gotten there is a different question, but they're at least talking about it and trying to think about it and address some of those questions. So they have made some pretty significant changes to the Medicare Shared Savings Program, which is sort of the primary way that CMS is paying for value. That does make it more amenable for lower volume and or new entrants into that program with an eye towards having it be more rural relevant. But there's also been some others. So there's a new Making Care primary model coming out. Minnesota is one of the states that's eligible to participate in that. Rural health clinics aren't eligible to participate though. So there is still some big misses in terms of where that's at. But I do think in general, hospital payment is going to be attached to quality, experience, and then overall cost, not necessarily cost just at your facility, but sort of that overall patient experience and cost of care. So I'll put a couple links in the chat to a few resources that kind of line that up. But I think I'm turning it to Ralph for kind of his vision next.
Well, I think that, when we look at the payment models, definitely there's going to be some movement to that 100%. And The hard part is we don't know what that means with cost yet. You know, could that be an adjustment on cost plus 1%? Could it be, you know, you could get cost plus 3? It could be cost less something, depending where you land. I think the most important part in the rural model is that we got to be thinking about how do we start looking at getting engaged today, because it's easier to get engaged before the penalties and the opportunities come than it is to have to learn it on day one when the penalties are already potentially there. So I think, Carly, you nailed it really well as to where it's going. Now it's getting people engaged to think about, okay, what does that look like in my rural setting?
You know, it was interesting. Dr. John Gale from the University of Southern Maine gave a presentation recently, and I'm still trying to get a hold of him to get the site on this. But the projection that he's looking at by 2030 is we may very well have 1.6 too many in-hospital inpatient beds. And in fact, inpatient revenue may fall by 35%, et cetera. So if we look globally, or we look certainly within national perspective, there is a growing recognition that inpatient revenue is going to continue to decline in that regard. So Ralph, as we talk about the whole range of activities of care coordination, do you see that the traditional services that hospitals have been providing, inpatient, outpatient, are going to expand irrespective of whether they're in an accountable care organization or not? Because I think we have both types of participants in this project, some that are in ACOs and some that are not.
You know, when you look at the inpatient volume is going to go away. I mean, not 100%, but it's going to continue to dwindle. And, you know, and I know a lot of people push back on that, but, you know, when I was a hospital CFO, the facility I was at, which is a critical access hospital now, it was 49 beds at the time. If you went back at that point, when I was there in the 90s, we probably ran 5, 6, 7 acute beds at a time. But there were stories about years ago when there were 50 beds and people in the hallways. You know, the model has changed. It isn't necessarily that the care is going to go away. A lot of the inpatient is going to outpatient. You know, there's going to be, you know, patients at home. You know, there's all these kind of different models are going there. So I think from the inpatient side, that holding on to what is there is important. But thinking that you're going to grow or expand inpatient, I think that that's just a real heavy lift if that's what the model somebody's going down. The real key is going to be figuring out how do we do all of the things on the front end, that outpatient side, either in the clinics or the outpatient hospital side, that's really keeping costs down long term. So when you think about population health, and we'll talk about it here a little bit, I'm sure, the facilities that should be scared about population health are the big brick and mortar facilities. The ones that are relying on slicing and dicing and all kinds of inpatient, high tech and all that there. Population health, if we make it work right, is going to move the cost to the front end. Yeah. It's going to change that model.
I agree, Ralph. I think really we're trying to get to a place where you get the right care at the right time and at the right place. And increasingly, that is not in an inpatient bed. When you think about kind of standards of care and what that looks like, you think about the safety issues, those types of things. How do we help ensure that in our rural communities and our rural hospitals, we're structured so that we can get people the services they need, but not necessarily in that inpatient bed? So whether or not that's supported through care coordination, whether or not that's kind of more some of the telehealth supports that might be at home, those types of opportunities I think are going to be really critical as we align with where both the payment system is going and where the way that we deliver medical care is going.
Right. I really like that piece on the, you know, align the right services, right time in the right place. And in my experience from the ACO providers that I've worked with in the rural setting, the process moves the expenditures of the dollars more to what I would call the front end, you know, i.e. the local provider, and less towards those providers that are on the outside or on the more of the back end. I'm thinking, you know, big pharma, air ambulance, tertiary facilities. It's moving the dollars, you know, which if you do it right, you can be doing those services.
Yeah, and speaking of that, a response from somebody who may just be becoming aware of this whole value-based payment system, or this idea that we're moving away from inpatient care. Well, traditionally and historically, that's where we have made our revenue. So if patients aren't going to generate revenue in the beds, then how are hospitals going to be able to survive with less and less inpatient revenue? Where are they going to make that up? And I think particularly as we're looking at the full range of services for care coordination, why should I do wellness programs, for example, if I'm a critical access hospital but not in an ACO?
Well, there's a lot of different reasons to be looking at, why you should do these. If you're in an ACO, you have the potential there of being able to capture some of the savings. So that makes it an easy argument for people that are in the ACO. But if you're outside the ACO, I think there are a lot of other arguments about why you still want to be looking at those other activities. And the piece is that there's a lot of outpatient services that can be paid for. And not only can they be paid for, but there's things that typically would have, well, one, they're the right thing, because they're the preventatives. There's the screenings, and there are all these other things that you can get into. But they've already been paid for by the beneficiary in a lot of cases. And what I mean by that is that every day, each one of us that's employed is paying in towards our Medicare eventually at some point in time. We've already paid those fees in. A lot of these services don't have out-of-pockets. So they're an easy thing to get the people the right things without having to tell them, oh, by the way, each one of these has a big price tag to them. A lot of these wellness things that we're doing, not all of them, but a good chunk of them are basically, quote, I don't want to say free because we've paid for them ahead of time, but they're already prepaid.
Yeah. I also think, so there's the services that you're getting direct reimbursement for, which is, Ralph speaks to that better than anybody I know. But then I come with quality lens. So it also aligns with the quality lens. So it's not, I mean, we have been talking, I think, primarily about traditional Medicare, but it also plays in your Medicaid. Minnesota's pretty advanced in terms of the Medicaid program with the integrated health partnerships, and with more and more commercial, where there are quality measures attached to a lot of these things. And those wellness visits, the care coordination services, all of those types of things are opportunities to help you ensure that you're both meeting and capturing and documenting the things that are required for some of those quality measures, which can drive people a little bit crazy. So I'm going to drop one more link in the chat. CMS did come out with an article earlier this year called they're putting out what they're calling a universal foundation for quality metrics that they intend to build into all of the CMS value programs. So that includes Medicaid and CHIP, as well as any of the CMS payment programs. So I've been working in quality measures long enough to have a little bit of skepticism. We have been talking about harmonizing and aligning and coming up with a parsimonious set of quality measures for at least a decade, if not longer. But this feels like a line in the sand to me of, here's a set of measures, and we're going to try to align this across all of our programs. And that's the piece that I find most exciting about it, is that all of our programs piece. It's still aspirational, but my hope is then it helps you who are on the front line get to the point where I really only have to be tracking this one way and documenting it one way, and I get the processes in place to help ensure people are getting their colorectal cancer screening, that our kids are getting our immunizations, that we're screening folks and understanding what their social determinants of health or their health-related social needs might be. And that is going to not only provide better care, but it'll also help me meet those quality measures that are going to be attached to payment.
And Carla, staying on this topic of quality, what has been the experience of rural hospitals participating in accountable care organizations? Have they been able to meet the quality standards? Has this been too heavy a lift for them? What's your perspective on that?
I don't have a study to support this, but my understanding is that the rurals that have been participating, in particular the Medicare Shared Savings Program, meeting the quality standards hasn't been the challenge for them. Whether or not they can kind of meet the financial targets is a little bit different, but we tend to see pretty high rates of quality standards. And I think that's because the rural healthcare system is primarily primary care driven. Most of the quality measures are primarily primary care driven. So it's actually, the alignment is quite good versus if you're in a system that is predominantly specialists and a little bit more fragmented.
Yeah, that would be
And
my experience too, Carla, from the ACO providers that I worked with, is that the quality pieces, well, there were some heavy lifts on the early front end. Once they got the processes and everything else down, and were able to figure out how they're going to track and record and all that there, I didn't have any providers that were being dinged because of the quality component.
Yeah.
And both Ralph and I were involved in the early stages of the Caravan Health, which is the largest of the accountable care organizations, primarily rural, or now they have a number of urban members. St. Luke's Hospital and all their clinics are a part of Caravan. So the St. Luke's out of Duluth. But what at least Caravan speaks to is that their quality scores are above the national average of ACOs, et cetera. And again, I think, as you're saying, that's not really very surprising, because so much of this is going to be primary care focused. And the other thing that we have found with the accountable care organizations is they're able to meet the financial goals, the quality goals quicker than historically than a lot of the great big healthcare systems, which is understandable to me as well, because we're smaller, we're more mobile, and so the track record for rural has been excellent. But there's been a general reluctance to get into any sort of arrangement where there might be financial risk as well.
Yeah, and I wouldn't say it's not without, I mean, there needs to be an investment in time and resources and how to use data and how, there's processes that have to be in place to be able to have those results. But I do agree with you, Terry, that we actually saw some folks leaving the Medicare Shared Savings Program, some rural sites who were early entrants because of the way that CMS had originally kind of ramped up risk. So that's some of the changes, that's the second or the third link that I put in the chat. Some of the changes that were made to the Medicare Shared Savings Program last year were in part to slow down that ramp to financial risk, because I do think there's been now some recognition from CMS that providers that serve rural and underserved communities don't have deep pockets. So if you force them to be in a situation where they're going to have to pay back funds, they're much less likely to pursue that. So I do think we're seeing a little bit of recognition and perhaps slowing of that kind of push forward in terms of financial risk.
Carla, could you just briefly talk about the new accountable care organization and the new model that CMS has rolled out, and the financial incentives for those hospitals that haven't participated to get involved?
Yeah, so it's not an entirely new model, but they have made a bunch of changes to the Medicare Shared Savings Program, which is complicated. It's like now I think there's A through F tracks now, I think, or maybe A through E tracks. And they have added back in, so a handful of years ago, there was something called the AIM model, the Advancing Innovation Model, if I'm going to get that right, where there was upfront payment that allowed for participants to have some resources to get the infrastructure in place. And those upfront payments were taken out of your shared savings once you had that. But if you didn't have the shared savings, you didn't have to pay them back. So that's been one of the features that, from a policy perspective, has been really important for rural engagement, because it does take some infrastructure and some process changes and data support to be able to be successful in these models. And so with the changes in the Medicare Shared Savings Program, they rolled them out. They're kind of rolling them out over the next couple of years, but they essentially reinstated that AIM program. So if you're a new entrant into the shared savings program, you would have access to that upfront payment. They also did a whole bunch of wonky changes around how they set the benchmarks and the baselines, because they were also seeing some folks technically get penalized because of the way that the benchmarks would get set. Because if you think about the big picture goal of the way that you are incented in the shared savings program is that there's savings to share. And at some point, as you improve care, as you do better on value, there's less savings to share theoretically. So they did some really kind of wonky technical changes around some of those benchmarks that were also more favorable for rural and underserved participants in the model.
And again, could you briefly also talk about the other payment model that they rolled out and may soon be rolling out again, which is an all payer model, which gets past, I think, a bit about what it's not necessarily all built on the savings.
So CHART and Pennsylvania?
Yeah.
Okay.
Briefly, yeah, because
Yeah. So there's the Pennsylvania rural health model it's in its 5th or 6th year now, and that's a global budget all payer model specifically targeted to rural hospitals in Pennsylvania. So they essentially, in the most simple sense, it's essentially like getting paid a salary. So they have figured out about how much each hospital should receive from all of the different payers, and then they get paid on a monthly or every 2 months, or every 2 weeks, depending on the payer basis. And then there's risk corridors and there's benchmarks around that, but then they need to operate within that. So you, as a rural hospital, get a global budget. You're going to get the same amount if you have 20 people in your bed or if you have 3 people in your bed. Again, lots of wonky details and spreadsheets like crazy to figure that out. But it allows then hospitals who participate in that model also have to develop a transformation plan, which highlights how they're going to improve care, improve efficiency, and kind of better serve the needs of their community. So if you can better serve the needs of your community by having a robust care coordination program in place, or by addressing behavioral health and mental health and substance abuse needs, you can use your global budget to do that, because then you can repurpose some of the staff that would be otherwise in your kind of staffing your inpatient beds. So it really has both like a transformation focus and a kind of global how you're getting paid focus. And they have been fairly successful in getting the majority of payers on participating in Pennsylvania. So the other model that CMS rolled out, but then now has pulled back, was called the CHART model, Community Health. I'm going to miss the A. It was similar. It was a similar model. Little bit more complicated in the way that they rolled it out. They had 4 states that were pursuing the next steps with that model, and then ultimately they ended up pulling back and are not going to be moving forward with that specific model because of it was complicated. They rolled it out in the middle of a pandemic. There's lots of reasons that they kind of rolled out, but CMS has definitely been thinking about and testing specific kind of rural models.
And you could almost say the transformation model could equate to a broader community care coordination model.
Absolutely, yeah.
And so
the one thing sorry for 1 second.
Go ahead.
The one thing to keep track on the Pennsylvania model is that while it is a global budget model for the commercials, for the critical access model, it really isn't. Because there is still the cost settlement. It's more of a balancing or leveling out of payments throughout the year, but it still does have the cost settlement model. So I'm not sure it's getting quite the potential benefits that they were looking at. It's just got some additional challenges because it still cost settles.
Yeah. So
thanks, Ralph.
And Ralph, if we think that we're moving in this direction towards all the commercial, the Medicaid, the Medicare, that's pretty much, as Carla began this session, that's the direction we're moving. For a hospital in 2023, what sort of services in that care continuum would you recommend that they need to be thinking about? And in the essence, because we can't do all things, what are just some components what's really important to prepare yourself for these value models and at the same time be able to realize some revenue?
Okay, yeah, and that's great. There's a couple of pieces there. Obviously from the Medicare perspective, it's easy to say which programs because that's a common across the country piece. Each payer is going to have something that may be similar or a little off from that. But the initial preventive physical that you get at age 65 as you enter the Medicare program, that's one piece. You got the annual wellness visit, you got transitional care management, chronic care management. And these are important because they all are services that open the door to other opportunities. They are the things that are getting you in to talk to your patients and line them up. And it'd be the same thing with commercial payers, but they may have different terms, but it's that wellness component. But when you think about getting them in the door for that, that's where you start looking at, what other services play into it. And when you do like the annual wellness visit and the initial program, that from a Medicare perspective basically puts you at the doorstep of over 25 other services that a beneficiary may have a need for. Now, you're not going to have probably a patient that's going to come in that's going to get 25 services, but there is a wide variety. And so I think the key is figuring out in those 25, what are the ones that we should be doing, because we can start to expand and increase our volume. So there are things like alcohol services, obesity screening, diabetes programs, lung cancer screening, tobacco use, counseling, mammography. A lot of the ones I'm working with are really using it to focus on how do you increase the amount of colonoscopies and colorectal cancer services that you're doing. And the thing is you look at these, is you dig into those that you can do already. So it's not necessarily that these are looking to add a brand new service. They might be, but it might be, how do I take from having 30 colonoscopies in a month to 60?
Yeah.
So you're expanding out what you're doing. So you're getting to people who aren't getting the services, which is an amazing piece. One of the providers I worked with years ago, when he started doing his annual wellness visits, he was blown away by the number of Medicare aged men that were not getting their colonoscopies, could never even get to that conversation in the past, were all of a sudden signing up. And when you do that, you kind of, you set up this time frame now going forward, that once you get the results, when the next one needs to be done. So now you get those into your ticklers files and everything about when you're going to market the next time, kind of like mammography, we got those time periods there. But it really drives that volume. And I think I would argue that with the chronic care management one, that's a great way to start looking at how do you improve your brand awareness. Because, when people start talking about their nurse or their physician that's calling them and checking on them on a regular basis to see how they're doing, making sure they're getting their appointments, which increases your number of clinic visits actually over time, helps reduce ED visits, which gets into the quality pieces. It reduces some of your inpatient stays. It reduces your readmissions. Again, another quality component, as Carla and I batter back and forth between quality and cost and revenue. You lay all those things in, but I think that those are the things you want to know, is go grab that list of 20 some services that you can get. And Medicare's got a website that just lays that all out. And it's updated on a regular basis. That's where you start. That's where you get your revenue from what I would say is your current patients.
Yeah. I just think that's such an important point. I've quoted you many times on this, because it's in everybody's interest. You're doing service for your patients, for your community. You're generating the volume of revenue through your outpatient services, where everything is going to go, which is what you're great at anyway. And there's such a win there. One thing that comes up is often that, okay, my physicians have to do these wellness visits? And then secondly, any thoughts on how we enlist the physicians behind this expansion of our care coordination and movement into value population health?
Well, I'm actually going to point to Amanda, because she's in the middle of it and doing it, rather than have Ralph and I be the talking heads about this.
Absolutely.
Let's do that. And by the way, Amanda is from Lakewood, not Lakeview. Lakeview is in Two Harbors. Lakewood is in Staples. So sorry, Amanda.
No worries. There's plenty of different changes. I just want to, kind of echo everything that you guys have been saying. I've been listening in, and, a lot of the keywords I've been hearing is, staying inventive, staying, everything's just ever changing. And that's absolutely correct. You could try one way one year, and then the next year you need to redraw it and look at how you're going to redo it again. What was our standard question that you brought me to?
How are you engaging your physicians in making this happen?
How are we engaging our physicians? A lot of it's, we have pretty strong suited physicians here at Lakewood where they like to be involved. They like to have those decisions. They like to be a part of it. In fact, our director for our healthcare homes program was a resident here at Lakewood and had really enjoyed looking at our care coordination programs and our medical home program. And that was one of her leads of wanting to come to Lakewood, was this program here and just everything that's involved with it. So getting our physicians involved, it's that continued communication, that continued education, but also letting them have some decision making in those leads and how it's developed and how it progresses.
And Amanda, let's talk about quality. Let's bottom line it in that regard. Do you think the services that we've been talking about, the tremendous work you do in your hospital and your entire healthcare system, has this improved the quality? And I mean, what does it mean for the patients in that regard?
I think it 100% goes down to the quality. I mean, you could look in the improvement of it. Just taking down some notes too as you guys are speaking, and it's not just specifically looking at the care coordination programs. It's not just looking at the patient and their disease and their prognosis and how are we going to manage that. It's looking at the outsideness of that patient and what else there is of that need. It's looking at their transportation needs and their food insecurities and their social determinants of health stuff. What Lakewood's been really good at is looking at those quality needs but also making more of a community development or community goals around it. So we offer out our food boxes. We have what's called a food pharmacy, FARMC pharmacy, that we are offering food boxes out to our patients. And we have every Thursday walk with a doc, where we have a doctor that's volunteering doing a walking around our campus here in the nice weather months, not so much the winter, then it goes indoors. But all of that has that impact when it comes to that quality of care for the patient. Way I always preach to my care coordinators too is that we can help somebody who has diabetes all they want, with med management and learning about their disease process. But if they need help and assistance getting to and from their appointments, that's where we're there for them too. And that's the assistance that's needed, because in the end, we're building it up for them to be successful. And it takes more than just that diagnosis lead or education for patients to do that.
Yeah, that's really terrific. Lakewood has been such I call it a national model, because we look to you folks. I talk about you all the time as examples. I say, okay, give us an example of where they've been doing anything about hunger. And so I said, well, there's this hospital in northern Minnesota, Lakewood, and it is positioning your hospital for the future. That is, we believe, the future role of rural hospitals. They are going to be community health centers, and they're going to have to deal with the social determinants of health. And you're kind of forging a way here that I really see so many hospitals following in that regard. Because in that value-based payment model, this is what you're going to get paid for, is all of these things. And the thing that excites me is that hospitals and folks that work in hospitals take on a greater role. They're able to do more things. They're able to impact so much of the health rather than just on an in-hospital basis. So I'm tremendously excited about it.
It really has a turnaround effect too, because we are a smaller community, we're a rural health community, but one person, one family sees and does these good things through Lakewood, they pass it on to another, which then can, you know, it all kind of entwines and circles in one another, and it's great.
And,
Yeah.
yeah,
Oh, well, I was just say the other nugget that I heard, Amanda, that I just want to highlight is that you had a resident come back because of the programs, because of the interest in the care coordination programs. And so I think everybody knows that, you know, recruitment of medical staff across the board is a challenge right now.
Yes.
So thinking about what's important, particularly to younger folks coming out of medical school, and how are you ensuring that you're able to kind of feed their soul in what they want to do as a medical provider, I think is an important tag that I just want to call out that I heard in your comment.
And I think a lot of it too, you know, going back to the providers and such, you know, it's the care coordination programs, and, you know, they're a helpful resource to the physicians just as much as the patients, because that way we have tabs on these persons for them and we are updating them as they need it. And, you know, it's helping them out too in the long run. So
that's such a good point too. I used to do admission interviews for medical students wanting to get into medical school at the University of Minnesota and UMD Medical School. And they were so bright and optimistic and driven. And a lot of these folks wanted to get in primary care in the first place. And after a couple years of medical school, it's like we beat out some of that enthusiasm as such, and rekindling in our medical population, I think is absolutely so important. And
yeah,
I agree that the new generation of just young people in general are seeking the meaning in their life rather than as being on an assembly line. Great.
Yes.
Hey, Ralph, I have a question. It's something that I think you feel strongly about. You and I share this. And that is the out-migration issue with our hospitals. One of the things that absolutely shocks hospitals is when they truly get a feeling for how much revenue they are losing because individuals leave for services they don't think are available, or they don't trust the hospital, et cetera. Talk a little bit about how care coordination and doing these services might lead to greater revenue through kind of stemming some of that out-migration.
Yeah, thanks for asking that. And that definitely is a topic that Terry and I talk about a lot, out-migration, leakage, whatever you want to call it. You know, at the end of the day, the amount of healthcare volume that leaves rural is often quite substantial. It's a lot more than providers typically want to acknowledge, either because they don't have the data, or they're just they don't want to acknowledge that they could be actually losing that much. And we're not talking just about services that, you know, are necessary to receive outside the service area. I mean, there may be things that are complex that they have to leave for the service area, you know, open heart, whatever. Obviously, you're not going to do that in a small rural facility. But the amount that you could be doing versus what you are doing is such a huge piece. And there's two areas that I see that you can try to capture more market share, reduce leakage. And one of them is around care management. The other one's more around access, and I can briefly catch that in a second. But really, when you start thinking about things like CCM and all these things, you know, I kind of mentioned earlier that whole concept of when people start talking about how they're getting their care to their friends, you know, hey, nurse so-and-so is calling and checking on me a couple times a month, making sure I'm making my appointments, making sure I have my meds. Back to Amanda's piece, making sure I've got some food. I got transportation. I've got all these things. That's all of a sudden something that they're not hearing from their outside provider all the time. And their outside provider isn't going to be making sure that they, you know, have transportation 50 miles down the road or 100 miles down the road. That's probably the types of things that aren't going to happen. But when you can start to get that concept of conversation going in your community, I think it sets a different tone. It sets a different brand awareness and all that. And I think you take advantage of that as a way to push things out. The other piece that really helps with market leakage is more about access to care. And so it's not so much a care coordination, but you could use the care coordination services around it. And that's really more about being more open more than 8 to 5 Monday through Friday. Because a lot of times when they're leaving because they work during the day. There isn't a local option. They go and hit something that's open until 6 or 7 in another community, and they can access that. So you take the two of those, and I think you can really start trying to drive some brand awareness, some reduction in market leakage. And when you think about it, when you bring in a new patient, it's so much easier to add substantial more volume than it is to add substantial more volume to a patient that's already getting a substantial amount of volume.
Mhm.
So you got to look at where your opportunities are. So yeah, Terry, that's definitely something you and I talk a lot. I probably talk to you more about that than anybody else about it, because it's something that's in our passion.
And you can get paid for those services.
And more importantly, they're the right thing that they should be getting somewhere. They might be getting them somewhere else, but they could be getting them with you. Because when I went through that, so many of those things in that 25 list, those aren't things that you have to go somewhere big to get them.
Yeah.
They're things that can be done locally. A lot of times it's just awareness. People not being aware that they can get some of those things in their local community, because when they drive down the road tells them, oh, we'll do that for you, because they will. They didn't say you could get this in your local community.
Yeah. And I'm just dropping in the chat too. The Rural Health Information Hub has a Medicare reimbursement strategies for rural providers for care management services toolkit that I want to make sure folks are aware of.
And one of the really important considerations here is, I think we have to think through what are the telehealth applications here, especially tele-urgent care, because as of now, I've got at least 3 or 4 options where I live north of Duluth, about 35 minutes. And if I need urgent care, it isn't just, let's say it's 11 o'clock at night and maybe we expanded the hours of the clinic, but I can have access to 2 or 3 different providers who also will write prescriptions for me as well. So this movement into particularly tele-urgent care to care in the home is absolutely something that hospitals have to think about. And it also speaks to why we want to get out into the community to let them know we have these services available. One of the things we might think about is we might be able to partner with another organizations to do tele-urgent care because presently we can get paid for it. And we're not sure about the future. This isn't necessarily something we're going to get forever. But every indication, and at least my indication, is absolutely this is saving money. The quality has been shown to be comparable, et cetera. So we are going to soon have more competitors than we've ever imagined. It's that this one is so obvious in that regard. It isn't just the hospital next door or the big healthcare system based in Minneapolis or Duluth or whatever. We're going to see, and it's coming. We're going to see these non-traditional providers. Dollar General is going to be putting clinics, kind of ambulatory clinics in their parking lot. They've really announced it. So now is the time, is absolutely not too early to be getting out and talking to the community. That this is going to generate more revenue for us. We can, so it's a perfect opportunity at this particular point. We have an advantage currently before the big guys are going to be coming in and providing kind of a new wave of competition as such. So to me, care coordination, particularly on the community based, is as urgent a need as we can think of.
Yeah.
And again,
I think Terry, on that urgent care piece, that's something that you can use the extended hours too. Instead of being open till 5, is being open till 7, and basically can use your current clinic as emergent care. And what we have found in some situations is by just adding those couple of extra hours, we can take care of a good chunk of what would be the urgent care that maybe you need to use telemedicine for. Because it's not emergent. I mean, obviously emergent, you don't know that that's coming, but urgent, if people know that by 7 o'clock I can see something, they might get into it. You might not catch all of it, but you can definitely see that those that have looked to extend the hours to give those couple of hours of open appointment times for more of that urgent, they can almost create their own urgent care center without having to set up a whole new structure.
Yeah. And what we've found with accountable care organizations is generally there's a tendency to expand those hours because it becomes really obvious that this is something that makes sense.
Hmm.
So if anybody kind of in the, in the hospitals that are listening has questions, either ask them now or you can put them into the chat. But I'm going to maybe close here because I think we've only got about 5 minutes with anything in particular, that a message that you guys can think of, that something important we might not have talked about, any kind of final thoughts. I'll ask all three. Amanda, why don't we start with you? Anything in particular that you've learned, or anything you could recommend to any of rural hospitals, not only in our little group here, but just in general? Lessons learned.
Lessons learned. I think, have a lot of trust and faith in those care coordination groups, in whatever level that you have them in. Lakewood has 3 different level of care coordination groups that we tend to, 3 different levels of patient panels. And a lot of that too, lesson learned would be, having that internal know-how and knowledge from those care coordinators is the best way to go. And that it strengthens Lakewood as a whole, the promotion of what services we have, but it also strengthens that relationship with those patients that are enrolled within it. Having that community-based person that knows the area, that knows the clinic, that knows everything, is really important. So relationships are the big one. Yes.
And in rural relationships are just
Absolutely.
super.
Yep.
Thanks, Amanda. Appreciate your participation here. Carla, you want to go next?
Sure. I think I wholeheartedly agree with Amanda. I would also add something we haven't talked about yet. That focus on right time, right care, right time, right place is really, really important. But you also have to be attentive to the details and documentation, because part of how you're actually going to get reimbursed for some of these things is because you've structured your workflow and process such that you're able to capture the appropriate documentation. So I think that's just one that we hadn't, we're not sure I put that as the most important, but it's one we haven't talked about yet.
Yeah, especially if you intend to get paid for it. Ralph, final thoughts?
Yeah, mine would be is that even if you're not sold that you're going to jump into value-based right now, there's nothing to be lost by starting to explore the services that we talked about, because it takes time. And if all of a sudden you decide, well, by September 1st, I have to have something up and running, you're not going to. It takes time. So I think doing that learning on the front end, figuring out what resources gaps you have, what you're going to need, start doing that, start thinking about things, exploring, talk to others, talk to people like Amanda and them about their experiences. We don't have to learn all of this by ourselves. In my experience, people are very willing to share what works for them. The rural model works well that way. But start thinking now, because it does take time.
Thank you both. So, Deb, you want the last word?
Well, I just want to thank all of you for attending, and also thank you panelists for taking time out of your busy schedules to offer some keys for wisdom here. And Faith has been launching those poll questions, so we should have all of those answered, and I thank you for doing that. And just feel free to contact either Terry or myself. And if you have some specific questions that either of us can't help you with, the two of us can reach toward Ralph and Carla and Amanda to get some of those answers. So I thank you for attending today.
Thanks so much, guys.